medications for children with cerebral palsy, autism, attention deficit hyperactive disorder, sensory processing disorders, learning disability, and handwriting issues in children. Some of the major achievements, honors, awards that she holds are: she is a certified master trainer in autism assessment tools from AIMS. She has been awarded Best Occupational Therapist Award from Santosh University. She is a certified GMA Level 1 therapist, certified music and movement therapist, and she is also trained under Alex Lopicolo, who is an international occupational therapist, also known as King of Swings. She is a certified drama therapist and also certified Brain Gym 101 training. She holds a training in neurodevelopmental therapy and sensory integration therapy from New York, USA. Holds a silver medal in certificate course on research methodology too. So a warm welcome to you, Dr. Mita Singhal. Before you go on to speak, I request our beloved director, respected director, Dr. Suman Kumar sir, to please address the gathering.
Thank you, madam. And on behalf of Aliyah Virgin National Institute of Speech and Hearing Disability, I welcome Mita Singhal, madam. And I already, our colleague Pratibha madam has introduced and informed us about all her illustrated career and achievements. So I hope this webinar will be an enriching experience for all of us, as madam will share her in-depth knowledge in the discipline and specifically for the person with cerebral palsy. So I request now madam to take forward from here. Thank you, madam, for accepting our invitation and being with us.
Thank you, sir. Thank you, sir, for the addressing. Over to you, Mita ma'am, Dr. Mita ma'am.
Thank you, sir. First of all, I'd like to thank Dr. Suman, Director, AYG NISGT, for inviting me for this webinar on the occasion of World Cerebral Palsy Day. And today we'll be discussing in detail about uniquely CP. I would also like to thank Pratibha Madam, Lecturer and in charge Psychology Department, for giving me this honor to share my knowledge on cerebral palsy with you. And it's a pleasure to be here. So we'll be starting with what is cerebral palsy, what is the theme. So
I don't know why.
Yeah, you could start now. You could start. Yeah.
So first of all, why we do call it as uniquely CP? Like what is the word uniquely CP? Why is World CP Day celebrated? It is a worldwide initiative which began in 2012, and it aims to provide community support research to improve the quality of life of people with cerebral palsy. So it is the theme this year for the World CP Day 2024, which was on 6th October. It encourages the people with cerebral palsy, their families, to share their unique experiences and passions. We need to talk about their contributions and we need to advocate equal opportunities for them. So I'll share a small success story with you. We had a child who was 5-year-old who presented with low birth weight, postnatal jaundice, from a very low socioeconomic status and having quadriplegic cerebral palsy. So quadriplegic is when all the 4 limbs are affected due to cerebral palsy, which is a neurodevelopmental disorder which occurs due to some factors around the birth period. We can say prenatal, before the birth period, perinatal, or postnatal factors, which may have led to this disease. So in this case, we found out the cause was delayed birth cry. The child was not able to sit independently and not able to do his age-appropriate physical activities. So when he came to treatment with us, we worked on his posture, range of motion, balance, mobility training. And all the positioning and training was done. And he was also advised some orthosis. So I'll share a video with you to show the improvements which we saw in the child. Explain.
Yeah, explain. Explain, ma'am.
So when he came with us, he was walking without the orthosis, and when he used to walk, he used to fall very frequently. He had his knees bent, friction, contraction, and tightness in the knee flexor muscle. So every time he's trying to get up, he's experiencing frequent falls, and he's having balance issues, not able to maintain his center of gravity while walking. So we advise bilateral ankle foot orthosis to him, and within a 8 month, 3 months, we observe that with the help of orthosis and therapy training, physiotherapy, occupational therapy, he was able to walk independently in parallel bars. Then we took him to stair climbing, walkers. So this child is now going to school. He is an independent child and he has acquired normal education skills. So he has been rehabilitated till the point of achievement. You can see very clearly he's walking independently.
So nice to see that success story out there, ma'am. Mita, ma'am. Yeah. Anything you in particularly want to go ahead, or I mean,
Yeah,
wanted
I'll
to
go
show?
ahead.
Yeah.
So these are some of the pictures also. He's also walking on the stairs post therapy. Before therapy, his knees were flexed. Now, we have cerebral palsy children coming to us, but there are certain challenges that we observe which highlights their uniqueness, which also interferes with their integration or movement in the society. First of all, the child is facing motor challenges. Motor challenges is the tone is increased, the muscle tone is increased if it is spasticity, or it may be decreased, or the child may be having some involuntary movements. Supposing he tries to reach for something, the moment he tries to do that activity, there are involuntary movements, so he's not able to complete that activity. So spasticity interferes with child being able to roll in the bed, to able to sit in the bed, to able to reach for objects, to able to have hand functions like if he's trying to feed himself or if he's trying to write if he's a school going child. So all these motor challenges interfere with the independence in the daily living skills. If the child is having involuntary movements, if he's trying to write, his hand will have tremors, he will have a shaky handwriting. So that also interferes with the daily living skills. He may have imbalance in walking. That is an ataxic type of CP. So the moment he is walking, he has a wide base gait. He may fall down. Or he may be hypotonic, like low tone. Low tone is not able to
Okay.
stabilize himself. There is a poor midline control. Whatever activity he's trying to hold the glass with both his hands, he's not able to take it to his mouth. Or he may be having hemiplegic, the half side of the body is affected. So he's not able to do bilateral movements. He's ignoring supposing his right hand is affected, his left hand is normal. So when he's trying to tie his shoelaces or tie his belt, he's not able to do these activities. Or he's trying to dress himself, he'll dress on half side of the body. He may have problems in the other side of the body. So these are the motor challenges which a CP child faces. Then due to the oral motor issues, like he's having improper mouth closure. The mouth is frequently open. So there will be drooling. There is a saliva which is coming out always. So whenever the mother tries to feed him, there is drooling. There is no mouth closure. He does not take the food inside. Solid food does not go. He cannot chew it. He cannot transfer from one side of the mouth to the other. Or there may be restricted tongue movements. So it prevents rolling of food into a bolus. So these children have challenges that mother has to give them a liquid diet or a very semi-solid diet so that he can be feeding. So swallowing, chewing, all these oromotor challenges, seizures, like whenever the fits, so the child is trying to progress, we are giving the therapy, suddenly a seizure comes, then there'll be a regression of milestones. Whatever he have achieved, the child may go back, or the child is not alert, he's on medication of seizures, so that makes him very, you know, sluggish. He's not cooperating. He's sleeping the whole day. So seizures create a challenge for the child in the therapy. Then there may be associated hearing deficit. If the child is not using hearing aids, if he is not listening to what we are saying, hearing deficit can also affect the speech and the sensory function of vestibular input. Then he may have visual deficit. Visual deficit prevents We are giving him toys, activities. He's not able to see if there is total visual impairment. So it's very common these days, visual impairment with cerebral palsy. So we need to train the other senses, tactile, kinesthesia, movement, to help him understand touch, feel, and coordinate the movements. Then there may be associated intellectual disability. Intellectual disability is low IQ or less IQ. Then cognitive functions are affected. So he's not following the commands of the therapy. He's not cooperating in the therapy. I am telling him to do something. He's not having that attention or concentration to grasp what is being advised. Then they have behavioral issues like tantrums. The child is running here and there, not listening to the parents. The parents are feeling that he's not following command. Whenever we tell him to do something, he doesn't want to do it. Or there may be excessive crying, excessive laughing, emotional disturbances, which may create a challenge for the child. Then, because of all these issues, the sleep pattern of the child is disturbed. Why? Because the reticular activating system does not know when to be attentive, when to go to sleep. So he's not sleeping properly. So it becomes a vicious cycle. He's not sleeping properly. He gets up in the morning. He's not alert. Second day, he's not able to do his activities properly. Again, his sleep is affected. So it goes on and on and becomes a vicious cycle, which creates a challenge for the child to go in the society to make himself feel a normalized person. Then they may have dental issues. They have a very poor dental hygiene. Sometimes ethetoid CP, which have involuntary movements, they have dental issues. Their cavities are very common. And these children may have a craving for sweets. So craving for sweets also creates cavities, right? Then they may have respiratory issues, like they may have problem in breathing, problem in, getting the functions, getting organized. There may be suction may be needed. Then they also have learning difficulties. So if there is an intellectual difficulty, the grasp will be affected and they may have learning difficulties. Now, what is the, how do we meet the unique needs of each child? Like, how do we start working with the child? Because every child is unique. Every child is different. No two CP child will be same. Like, even if we have a spastic CP, if we have a thetoid, two spastic quadriplegics, they will be, two will be different. So first step is when we start dealing with the child is a history taking. It is very important to gather the proper history from the parents, like why did it happen. Sometimes we get some things in history, sometimes we do not get it. There are prenatal factors, like mother has been exposed to a lot of x-rays, limited some drug intakes, like she has not taken proper antenatal cares or vaccination, or there was poor nutrition in the mother, like we have in the low socioeconomic status, or any kind of folic acid deficiency, which maybe have created these problems. Then there are perinatal factors. Perinatal factors means something happening around the birth, like the umbilical cord got around the neck of the child, or the child did not get proper oxygen. There was a delayed birth cry. Or there is fetal hypoxia due to hypertension in the mother, diabetes mellitus in the mother, or any infections like prenatal period, the mother had torch infections, measles. All these things can be creating problems at the time of the birth. The commonest cause which is seen is birth asphyxia or the delayed birth cry, which creates or which creates a problem that oxygen does not reach the brain and there is damage in the brain, and the part of the brain which is damaged is irreversible. So it's a neurodevelopmental disorder and the damage is irreversible because neurons do not regenerate. We all know that. So we have to tell the parents to accept that fact that whatever damage has occurred, hypoxic encephalopathy may have occurred grade 1, 2, 3. So all these things may have caused the damage to the brain. Then it is also seen in the postnatal period. Like postnatal period, the child had after birth, when the child is born, there have been seizures or there has been some kind of infection like meningitis, encephalitis. All these things can lead to cerebral palsy. Also, there is a preterm baby. Like if he is born before 36 weeks, preterm children are also prone to cerebral palsy. They will not, they will take time because they have come before in this world. So it takes time to get adjusted to the world. They will be low birth weight. So they need kangaroo care, a lot of care to prevent the problems. So first step is we have to gather the history to identify the cause of cerebral palsy. Then when the mother comes to us, she may not come right from the birth. These days, the referral comes early because there is a lot of awareness that if there is any high risk factor, they are referred to the therapy institute. But if they are not referred, they come at a later age, they come at 6 months, 1 year. So we need to take the milestone history. Like, what are the milestones the child has achieved? Every child has a developmental milestone. It is a motor milestone, personal social milestone, behavioral milestone, and adaptive. So motor is gross motor and fine motor. Gross motor skills are like, when did the child roll? When did he achieve neck control? When did he start sitting? When did he start standing? Was there a delay? So we have norms like 3 to 4 months the neck control will come, 5 to 6 months the sitting will come. So we have a standardized protocol. We have different scales like Denver's developmental scales, etc. for screening the child, like what were the milestones and when were they achieved. Then we need to check the developmental reflexes. Developmental reflexes as a sign of the neurodevelopmental maturity of the brain. The brain is getting into myelination. First, there is myelination in the lower centers, then in the middle centers, then in the higher centers. So reflexes indicate us that what myelination is complete and what level the child has reached. So there are lower reflexes like moro reflex. Supposing I give a clap to the child, he will move his arms outward. I stroke on the outer corner of the mouth, the child will turn his face towards that. So these are reflexes which are telling us that the child is developing normally. A 1 year old child will not have moro reflex. Like there's an ATNR reflex. I turn the head to one side, his head will extend and his one arm will flex. So that will prevent rolling. If that reflex persists, it will prevent the achievement of milestones, it will prevent the rolling. So we need to check the developmental reflexes will indicate us like why the milestone was delayed, where the child is stuck. So that will be a guideline for therapy, where I need to start, where we need to work so that the child does not have issues.
So
Then
typically, ma'am,
we need to do a muscle
excuse me.
tone assessment. Muscle tone is assessment. Yeah.
I said typically
Hello. Yes, ma'am.
typically these reflexes have to resolve within a particular period, isn't it, ma'am? Once it comes, after some time, it has to resolve. It should not
No,
persist beyond.
they have to integrate. Normally, they have to
To
integrate.
yeah,
Yes,
okay.
they should not persist. If they are persisting, that means there is a delay in the developmental milestones. Yes. This case
Thank you, ma'am.
for modified Asheville scale, whether it is an increased muscle tone, low muscle tone, because we have to normalize the muscle, right? Then we look for signs of upper motor neuron lesion. There is a DTRs are brisk, the development reflexes, the Babinski sign is positive or not. So that indicates an upper motor neuron lesion, which is cerebral palsy when we are checking for it. Then we also need to use any standardized assessment scales, and we need to take the feeding history. What will be there is if the child is having palsy, that will be a high risk child. The mother will complain to us that the child was not taking proper feeds. He's having problem in taking the mother's feed. He's not sucking properly, or if he cries excessively, he's not a cooperative child. So there are early signs of cerebral palsy, which I'll show you in this picture. So if we observe the child, if we look at this picture, the child will always keep his trunk in backward and in an arched state, a cerebral palsy, spastic child. If we are looking at a spastic child. So this shows arch. So moment we try to pull him to sit or we try to bring him close, his back will arch excessively, right? Then there is another high risk. Then he'll always
Can you
knees
others please mute your mic?
because the tone is increased. So moment we bring him to start, he'll scissor his legs. The legs will cross. There will be poor sleep pattern. There will be poor feeding. So all these issues which indicate that the child may have cerebral palsy, because before 2 years of age, we can call him a high risk child. We cannot draw a diagnosis. We need a proper variety of symptoms, signs to check, to do a diagnostic assessment, MRI, CT scan, which may be normal sometimes in cerebral palsy. Sometimes we may observe some signs in it. So even if we have to draw a diagnosis, we need proper diagnostic tools to assess and say that label the child, because we can't label. These are just the high risk signs which may be observed. We are drawing a diagnosis. History is there. The mother is complaining. We are observing certain signs. We are checking the upper motor neuron signs. So all these assessments will give us a guideline. And we have the modified Ashworth scale, which is a scale which is used to assess the muscle tone, which is from 0 to 4. 0 is no increase, slight increase. I'm not going into details. And we also have standardized scales like Bailey scales, Denver's developmental schedules. All these scales, Baroda screening test, Indian scales are also there, which will help us to draw a standardized score on where is the developmental level of the child. Because when we need to objectively measure the progress of the child, we need to have a standardized developmental score. Otherwise, I can't measure what is happening, how is he improving. Then a commonly used scale in cerebral palsy is GMFCS, General Movement Assessment Functional Scale, which is a scale which is from level 1 to level 5. Level 1 indicates he is able to walk independently, school, outdoors, community, everywhere. He has no problem in stair climbing. Level 2 indicates that he is able to walk in motion and climb the stairs but holding the rails. Level 3 says that he's able to walk with mobility device in most indoor devices. It may be a walker or it may be a wheelchair. Level 4 tells us that he needs assistance with someone to make him move with an assistive device or a mobility device. He may be using a powered mobility wheelchair. Level 5 indicates that he needs almost wheelchair, is totally dependent in all his activity. So GNFCS is a commonly used scale with cerebral palsy. Then we also have activities of daily living scales, which tell us the independence in daily living skills like feeding, mobility, what dressing skills. VFM is the commonest scale which is used. It is an 18 item, 7 level ordinal scale, which measures self-care, mobility, and cognition. There are also certain balance tests like time up and go, sit to stand, pediatric reach tests. So these are standardized scales which we can use. So I've already shared the success story. One more success story I will show you. This is a child who came to us and he was having problem. He was keeping his knees together and flex, and legs are internally rotated as we can observe. So he received physiotherapy, occupational therapy exercises, and after 3 months of continuous therapy, he was able to walk and stand independently without any external support or devices. And his GMFM score improved from 52% to 85% without aids and appliances. So that is an achievement, that the score increased so much. Now, if we talk about family involvement, like what role does the family play? Family is the pivotal role in the management of a cerebral palsy child. Family is the, we can say, the center, the hub, which is going, everything is going to revolve around the family. The parents have to first acceptance. What happens is, the moment we tell the child that your child has a problem, he will not be able to do this. So there is a lot of grief, sadness, anger, regrets that why it has happened with us. The acceptance does not come easily. So it has to be, you have to explain the parents, counsel them that even if the problem is there, they should focus on the abilities of the child. The child is differently abled. He is not disabled. The term we used is differently abled. He is doing something in a different way, but he has abilities which can be retrained, which can be emphasized to make him independent, to make him part of the society and move in an inclusive society. So parental counseling is very important. Then training the mother to how to handle the child, because it is generally seen that the mothers may not hold the child properly. We may have mothers from low socioeconomic status. They are just pulling the child with both the hands. That will create a increase in the muscle tone. Then they will do massage. They will may go to pehlwans and all, and somebody.
And let's just wait. I think there is some internet issue on the resource person side. Kalpita, you may tell the audience that there is some internet issue on the resource person side.
Sorry, I think there was a network issue.
Then we could try sharing once again. Yeah, yes, the PPT. Yes.
Yeah. You can see my slides.
It's visible, ma'am. Yes.
So we have to, I was discussing how to train the mother to how to handle the child. Then behavior therapy, like how to deal with the behaviors. It's not every time the mother will or parents will scold the child will listen to them. We have to create a balance that how to encourage the adaptive behaviors and how to avoid the maladaptive behaviors. So madam can tell more on this rather than me. Then we have to prepare them for the school. What are the preschool preparations we need to do? Like what will be the prerequisites of the child, what the child will need before he goes to a school? Like how to learn to sit down. These children are sometimes, they don't know how to sit down for long. A school will be a long day for them. So how to learn to sit down? What are the fine motor skills the child will need, like holding the pencil, putting his things in the bag, having the social interactive skills, like how to interact with the children, how to learn that when the teacher is teaching, how to note down. All this preschool preparation has to be done. Then we have to counsel and guide the parents that there is 5% reservations in the school and they can go for inclusive education and no school can deny them the admission as per the Directorate of Education. So they are the guidelines. If they deny them, they can go and complain. Then after the schooling, then we need to counsel come at a later age. What are the pre-vocational skills? Because the parents want that the child should be financially independent and not dependent on them. So we need to carry out that pre-vocational screening, understanding, and guide them that there are 4% job reservation as per the government guidelines. And it is a mandate for all the governments to have this reservation and create the post for PWDs. So we have to orient them, guide them, show them like what are the benefits they can avail as per the guidelines, that what are the benefits of the government. They have income tax exemptions. All these benefits have to be counseled and told to the parents. Then what is important is when we are working with the child, we can't impose things. Like if the child does not like something, I can't make him do. After all, he's a child. So play therapy plays a very important role when we are treating them. I may give him a toy which he hates, he likes. So I have to find out what he likes. Whatever toys we are using, whatever tools we are using in the therapy should be of interest to the child. If he likes music, then I'll integrate music in the therapy. If he likes dance, I may use some dance movements and actions to make him independent. If he likes swings, I can incorporate swings to indicate. If he likes horse riding, there's something called as hippotherapy. Hippotherapy also helps to, there's an institute in Bangalore which they practice hippotherapy. Hippotherapy helps to stabilize the hips, get proper movement at the pelvic mobility. It helps to legs to keep in abduction when the child is sitting on the horse. When he is riding the horse, there's vestibular input, which, stimulates the muscles. So hippotherapy is a very good technique which is used. Then swimming, aqua therapy is very good to release the muscle tone. The moment we take the child in the water, we remember the buoyancy principle. When we go down, we feel light. So when we do, muscle tone releasing exercises under the water, the tone normalizes very easily. Then we can use creative skills, movement therapy, guiding the child through various movements, drama to, use it to help identify his creative skills, what he can do. He may become a actor later on. Then drawing, painting. These children sometimes have good fine motor skills, like diplegic cerebral palsy children have normal hand movements. So we can make the child make very good paintings. Then we can make go for drama therapy. We also know children have participated in sports, Paralympics. They go for Paralympics, wheelchair Paralympics, wheelchair sports is there. So they can win a lot of awards. They have done it. So I'll also share the famous people with cerebral palsy, Stephen Hawkins, Christy Brown.
We have lost ma'am once again. I'll just check with her.
Adaptive skills or tools which we can advise to the
We have again lost contact with the resource person. We'll just get back after having a word with her. Yeah, ma'am is back. Yeah.
issue. Yeah. Can you see the slides, ma'am?
Not yet, ma'am. It's saying it started sharing. Yes, right now the slide is on adaptation at home for lying in prone and supine position. Mita, ma'am. Mita, ma'am, are you there? The slide is on, but I think she's not able to listen.
Just that they take a tree and
Mita, ma'am. Mm, looks like again she's got logged out. Some internet issues, Kalpita. Please communicate. There's internet issue and she's facing problem in logging in, logging out. She's having issues. So we'll just try to rectify this. Please be online.
it's visible, ma'am.
Yes, ma'am. Now the
So
adaptation at home
we
for
were
lying.
discussing about the adaptive devices, like they can just take a, a shawl or a chunri, and the mother used to tie the child and put some toys. So it's a hammock. Hammock is a very good adaptation for a cerebral palsy child because it corrects the complete posture of the child. The child is keeping his trunk hyperextended, arms outward, legs extended. So immediately when we put the child in such a position, the whole body comes in a state of flexion. So it integrates all the reflexes. It tries to bring the hands in midline. It keeps the legs in correct position. So it's a very simple device which we can suggest the parents at home that they can just take, and tie this maybe trees or some two sticks they can take and use it. Then we also have a corner chair. Corner chair can be adapted at the home, like they can take the corner of a sofa or a corner in any corner in the house, put two pillows and make the child in the center, and then it will bring the hands forward. They can
Polling.
keep the pillow
Wait.
in
We
prone
have to do it.
position like a
We have
bolster.
to do right now.
One side is low. Then if the child is not having neck control or is not reaching for objects, this will help the child. Then I was telling how to use play. This is a cerebral palsy child who had ethitosis. So what was happening is he did not have a midline control and reach. So what we are doing is he is on a therapy ball. The therapist is holding his pelvis, guiding the movement and stabilizing the pelvis at one hand. That is a neurodevelopmental therapy technique, and that is encouraging the movement in the upper part. Having play, and we are combining it to use and develop so many skills: gross motor skills, fine motor skills, reaching skills, eye hand coordination skills. So it's a multiple play therapy activity, making the child feel, enjoying the activity. So he's doing it as a play, but as a therapist we are gaining a lot of movements out of it. Then positioning in the classroom is important. So if it's a cerebral palsy child, he will need a proper adaptive CP chair to sit in the classroom. Or he may need a standing frame if he's having issues in sitting. Then it is very important there should be a pad which stabilizes his head. There should be a pad, sandbags to keep his arms in correct position, padded blocks to keep his shoulder in proper abduction. There should be some thigh pad in between, so that what is happening is when we are placing him, he should be not having a problem in keeping his legs. The legs should be properly abducted, because they have a tendency that they will keep their legs in a adducted position. Scissoring is common. Whenever they will sit, they will stand, their legs will cross. So if we don't position it properly, the adductor spasticity of the muscle tone will increase. Then the foot should be properly placed on the floor, or we can put a foot pad so that the feet are in proper position, because ankles will have a tendency to go in plantar flexion. They will be like this. So we want them in neutral position and stabilize with a proper foot board. So positioning in the classroom where the child is going to spend 7 to 8 hours is very important, because a wrong posture will encourage more spasticity. So these are called as reflex inhibiting postures, RIPs, which is an entity technique which through proper positioning devices which we maintain. Then there are some misconceptions about cerebral palsy. People feel that it is some sort of polio. Some people have a myth that it is contagious, like it will spread from one person to another. If a CP child sits with a normal child, then he will also know. It is not contagious. Then there's a myth that all the cerebral palsy children are intellectually challenged. They have cognitive issues. No. CP child may have normal intelligence also. He may or may not have an intellectual issue. Then all the CP children can't talk, they are hearing impaired. No, not necessary. They may have normal hearing, they may have normal speech. Then medicines can completely cure CP. Some parents go to the quacks, they say, okay, take these medicines for 6 months and it will be absolutely fine. No, it's a neurodevelopmental disorder. There has been brain damage. It will not recover completely with medicines. Then there is a myth that parents say, okay, koi baat nahi, jaise don't need to do anything. No intervention is needed. Some people will tell them, no, it's not. If they don't intervene, the child will not improve automatically. There is a necessity that proper intervention should be given. Then there's a myth that all cerebral palsy children are locomotorily disabled. They need a wheelchair. They are classified under locomotor disability, but now there are 21 disabilities, so it has been independently classified as per the RPWD Act. But it's not necessary that all CP children need wheelchair. Then they cannot be a part of mainstream. There's a myth that you have to put them in a separate school. No, they can be a part of mainstream. They have normal intelligence. Even if they are intellectually impaired, we can do some adaptations in the curriculum, and it is said that we should make them a part of the mainstream. Then there's a myth that they can't work. Career choices are limited. No, there are government reservations. In our college, we have a CP ethetoid child who is doing bachelor's in physiotherapy, and he is in third year, and he's properly managing everything. He comes every day to the college, he is walking, and he is studying. So they can go for medical classes, they can do all the courses. There are variety of career choices. Then there's a myth that it has a short lifespan. No, they may lead a normal lifestyle. Last time we were discussing in a webinar, we had a success story of a 60-year-old CP child, and he was sharing how he has lived his life. So they can live a normal lifestyle. And there's a myth that they can't have a family life. They can be parents, they can have children, they can have a normal family life, they can be proper part of the society. So these are all just misconceptions. Now, how do we do, what strategies, what techniques, how do we work when we work with a CP child? Technically speaking, we have different techniques, but the first step is early identification, early intervention. The day the child is born, and if there is any high risk factors, like I already explained, that if a high risk factor is there, that he had some prenatal issues or perinatal issues, masters in 2001, 23 years ago. Then my research was early intervention in preterm infants. So that was my research topic. So that time also I was the first person to start, that research, and, I used to run NICU and tell the doctors, the neonatologists, that how early intervention is important. You need to refer the child right now. So the moment a preterm child was born, I used to go and counsel the doctors and tell them, you have to refer them early to prevent. And then I did a 1 year longitudinal study, and we saw that even if it was preterm, the incidence of CP diplegic was lower if we started early intervention. Then we can use direct instructions, we can use role modeling, computers, videos, we can use awareness programs, we can do parental trainings. Like if I tell the parents some success stories, and they also, if the parents attend today's program, they will understand the importance of early intervention. Now, there are certain problems which they face at home. Like the child may have poor neck control. So for that, we have different adaptations. Like I already told, we can use a wedge, we can use toys. Then the child may have issues in rolling. We need to teach the parents different rolling techniques are there. Rolling from one position to another. Then the child may have problem coming to the sitting position. We need to tell the parents and guide them on appropriate sitting postures, how to maintain sitting posture, how to keep the child cross-legged. Then the child may have issues in standing. Now, how occupational therapy can enhance social participation. What is there is, if we look at the ICF model, it is the international classification of WHO model. Cerebral palsy, the body functions are affected. That is, the child has spasticity, he will have pain because of that, he may have speech issues. This affects the activity performance, like doing his self-care activities, mobility, playing with friends, volunteering. This affects the participation, that is communication, attending school, going for movies. All this is affected. Now, there are certain factors which, as a rehabilitation team member, which we can modify, which we can create. One is the personal factors. I have to motivate the parents, motivate the child, fix the priorities, the goals according to the age of the child. And there is the environment which I can control. Environment can be modified as per the need of the child, need based. That is making the environment accessible. Accessible means creating an inclusive environment. We all see that these days having an accessibility environment is compulsory, like malls, everything, social places, public places, gyms, movie theaters, railway stations, metro stations, everything is being made accessible, that it is having ramps, railings, so that a wheelchair bound person does not feel out of the society. He is inclusive in the society. Then we provide adaptive equipment if they are needed. Then we need to provide proper support. We need to modify the attitude of the parents, like what you are doing is you are doing it focusing on his abilities. Then we need to have washrooms are accessible. If we go to malls and all, you will see a special washroom for a disabled, a parking which is marked for a differently abled. So washrooms are accessible, proper sliding doors, proper railings, proper toilet seat height. Then we need to reduce the attitudinal barriers. We don't need to look at them at a person who can't do anything. They can do everything. We need to adapt to them. We need to create the environment they need, not don't need to change. If I can't change, then why should they change? Let the environment be created for them. Then we can make them participate in physical activities. Then if they want to do financial skills, there is NHFDC, which provides loans to these children to start their own private business. Then if they want to go out and play, there are inclusive parks which have swings, which accommodate the wheelchairs and all. So we have to create a inclusive society, make them feel a part of the society. Now, how do we think that cerebral palsy impacts a person's self-esteem and body image? Now, what happens is they feel socially isolated, because if a child is wheelchair bound, he's intellectually disabled, he's not moving in the society. Parents are not taking him for birthday parties, for social gatherings, or outside in the malls. They will take them when nobody is there. So they feel socially isolated. They have peer rejection. They are not accepted even by their brothers and sisters. They will not play with them. They will make them feel rejected. So what happens is this affects their self-esteem also, because they are not competent. It is right, they are not competent with the norms. So there are a lot of barriers which are created, and that affects their education, employment. So that lowers their self-esteem. If they go for an interview, they are rejected, their identity, their skills are not identified, then their integrity is also affected. Now, what are the unique sensory challenges they have? They have a lot of sensory issues which affects their ability to interact with the environment. Like they have sensory-based disorders. I can share a video if we have time now. In the end, I'll show one video.
Yes, ma'am. Towards end, we could take up the videos and we could show.
Yeah, in the end, I'll show. So they have sensory issues like sensory-based motor disorders. It has been seen that 73% CP children have sensory-based motor disorders. And they also have issues in movement sensitivity, that is the vestibular system. 60% of cerebral palsy patients have this. And visual and auditory sensitivity has been seen in 20% children. So sensory challenges they face, for which we have sensory integration therapy. Now, how do we set up the goals? When we are setting up a goals, it is a collaborative approach. If we empower the parents, I tell the parents, like, what do you want first? See, I may say that I want the child to go to school first. Parents say, no, school is not important for me. I want the child to walk first. So you work on his walking skills. Education can wait. So we have to prioritize what are the needs of the parents, what the needs of the child, and what are the skills of the child. Everything has to be taken into consideration, and goals have to be collaboratively sorted out. Then there are short-term goals and there are long-term goals. My long-term goal will be to make the child go to the toilet independently. But before he goes to the toilet independently, I need to achieve a short-term goal within 6 months, that the child is able to stand independently. His muscle tone is normal. He is able to take 10 steps in 3 months. So these are short-term goals. Short-term goals will lead to my long-term goal achievements. There are different goal-setting tools. It was called as a SMART goal. SMART goals means SS, goal has to be very specific, measurable, attainable, relevant, and timely. So if I say that the child will be able to stand independently for 5 minutes twice a day within 2 months. So it is specific, it is measurable, it is attainable, and it is timely. I have defined the time period. That is the dosage. I will do this much time, I will achieve this goal. So these are the methods, standardized tools for, there's an ABCD method, there's a COAST method, Goomba method. There are different methods of assigning the goals. Then how we can use technology. Technology plays a big role in cerebral palsy. If the parents are able to afford a powered wheelchair will lower the energy expenditure for the child. If the child is using a manual wheelchair, he'll get tired easily. He will not have that endurance at the end of the day to give his energy in his skills, like if he's going for his work. And if I give him a manual wheelchair, by the time he reaches, he'll be tired. A powered wheelchair will have a joystick which will operate with a power device. So that will be easier for him to travel, faster will be done. His energy expenditure will be less. He will conserve his energy for the work he wants to do. Then we have environmental control units, like with the power of a switch, he can open the curtains, turn the lights and on and off if he is totally quadriplegic and wheelchair bound. Then we have augmentative communication aids, which help to create a communication if he's having a speech issue. There are softwares like even just point to that, touch to that, I want food, I want to go to the toilet. So it's a augmentative communication aids. We have AI, artificial intelligence. They can have a VR mode and they can do movements and practice. We have robotics. Tele-rehabilitation has come up. Then online, we are training the parents how to do the things. Then how do we assess the progress? Progress, I have already discussed the tools, assessment tools are used, like the gross motor function test, gait attainment, pediatric balance scale, quality of life, Pathal index. All these scales are standardized scales will objectively give me a score which will help to measure their progress. Now, what advice we have to give to the parents? It is very important, the mental health of the parents. If they are under a lot of stress, pressure, their emotions go into the child. If the mother is relaxed, she's calm, she will be able to handle the child in a calm way. So we have to train them to be stress-free, to be relaxed. Then they have to understand what are the emotional needs of the child. The child may not be the same every day, because as a normal human being, we all also are not same every day. Sometimes my mood may be good, sometimes it may not be good. So we have to accept it that he is also having emotional outbursts and how they have to handle his emotional needs. Then they have to spend quality time with the child. They don't need to isolate him, that they put a maid, the maid will take them to the doctor for the therapy, bring him back. So that creates a very isolation and a gap between the parent and the child. So we have to train them, spend quality time with your child. Then be a role model. Right? I have to show them success stories, other children who have achieved. Then they have to boost child self-esteem. Like if he has done something good, make him feel, give him some positive reinforcement, give him some tokens like, you have done these things properly. So 10 proper things, you get a token. And now this token, you can buy some extra time for television. So token economy, all these things can be done. They can join parental self-help groups. There are a lot of parents who help each other. There are a lot of parenting WhatsApp groups. We are online. So we can make them share their knowledge, share their experiences, and they have to focus more on the strengths of the child, not on his weaknesses or not what he can do. So let us look at some government schemes which are there for the children with cerebral palsy. There's a scheme of National Trust, which is Disha, which covers 0 to 10 years. It is a national trust scheme and it provides early intervention for person with disabilities through training. It is free of cost, like the RO will create, and at least 4 hours a day that they can take the child there for a age-specific activities. So they are funding these or things so that the parents can get treatment free of cost. Then there's another scheme called Vikas. Vikas is a daycare scheme. It offers interpersonal and vocational skill training for the children with cerebral palsy and persons with disability. So there are also daycare facilities in which they can go for 6 hours a day. Then there is a scheme called Garunda. Garunda is for persons with mental retardation, autism, CP, who have multiple disabilities, because CP may have multiple disabilities, and they provide full living standards, medical care, vocational activities, assistance, support. They can stay there, they can have a proper home for it. Then we have the Nirmaya health insurance scheme, in which they have to pay a premium, in which they get 1 lakh insurance for OPD services, medicines, diagnostic tests, dental, surgery. Everything is covered under this. And for BPL, it is 200 rupees a year. And for the normal people, it is around 500 rupees. So it's a very reasonable insurance scheme for them. Then we have the Gyan Prabha Educational Support Scheme, which provides the people with autism, CP, MR, multiple disabilities who want to pursue educational or vocational courses and pre-vocational training. So it provides a specific amount of fees. It provides pocket money, expenditure, transportation, everything is covered for them. So if they want to study. Then we have the Prerna scheme. Prerna scheme is a national training scheme which provides funds to these people to organize events such as melas, fairs. So whatever things they have made, they can go and sell out in this mela. So this is to encourage them self-independence, to be financially. Then we have the Sambhav scheme. Sambhav scheme assures that they collect all the aids, softwares, all the devices which they need are provided to them free of cost at the National Trust Fund website. Then we have the Badhte Kadam scheme, which is a awareness and community interaction, in which the National Trust focuses on doing awareness program, that every center should do at least 4 events and conduct 1 event for community educational. Like we are doing this webinar. This is a part of awareness program to create awareness, sensitization about the topic. So what is the importance of multidisciplinary approach? Like cerebral palsy starts right from the diagnosis, when the child is seen by a pediatrician, neuropediatrician, screening is done, then the child may be referred for surgery or surgical corrections. Then we have a physiotherapist, occupational therapist, speech therapist, a psychologist, a social worker, a vocational and pre-vocational counselor, a special educator. So all these, a prosthetic and orthotics, a recreational therapist, a pre-vocational counselor, all these team members, they work individually to create, help the parents, help the patients to be independent in their daily lives. So no person is replaceable. We need all of them to work with the child, to identify every person has their individual role to play. We also have the interdisciplinary approach and the transdisciplinary approach these days. The transdisciplinary or the cross disability centers. What happens is parents get tired, the child gets tired running from one room to another. So we have group therapy sessions, like one person will do all the things in one day, so that the child also gets a change, and we cover up everything. We retrain each other, we empower the other person, we are not in competition with each other. So the cross disability approach reduces the stress on the parents. So these days the cross disability centers have come. So we have adaptations. We can have no tech, low tech adaptations, softwares. I've talked about, adaptive devices like pencil grips, starting boards, seating devices, papers, wheelchair tray, adaptive tools for feeding. Like they may have adaptations in the handles of the spoon, toothbrush, fork. We have positioning devices. This is a sideline positioner. If the child is not able to sit properly, we can give a sideline position. Then we have the corner chair, CP chair. This is the corner chair. Then we have different standing frames. I'll share more devices. 1 second. Yeah, this is visible.
The screen is coming on, ma'am. Yes, push. Yes, now it's visible, ma'am.
Visible. So these are different positioning devices which we can use with the children. That this is a bolster. This is used to make the child sit with legs in abduction. This is a wedge that I had shown in the pictures. Then this is a corner chair. So the child is playing easily. There's a cutout table in the front and he can have toys. This is a crawler which we can use. This is a walking line. Then we have parallel bars training in the walking. So these are different adaptive devices which we can use. So, how do we encourage clients to embrace their uniqueness? We need to empower the parents. We need to boost their self-esteem. We need to make them vocationally, financially independent. We organize different melas like Divyang Mela, Divya Kala Melas. All these things are a motivation factor for the parents. Now I'll just share the video. Is my screen visible?
Not yet, ma'am. I mean, not yet. The sharing is not yet happening.
Okay, 1 second.
Yeah. Yeah, now it says has started screen sharing, but yet to come on the screen. The
Yeah,
video
okay.
is. Yeah, yes, ma'am. But the video is not yet started playing.
I think the network issue. 1 second.
The ad is coming up in between. YouTube ad, I think. Are you able to do it, ma'am, or some difficulty there, ma'am? Means
You
even
cannot
this.
see it?
No, not that's what. It's totally gone. Only the video participants are there on the screen.
There is no, you can't see.
No, means you're not sharing. You've not started
I'm
sharing yet.
sharing it.
Then
1 second, I'll share it again.
it's not visible to us, ma'am.
1 second, 1 second.
Yeah. And now it says
Now it's visible?
has started screen sharing, the blank screen. So
Now it's
yet to
visible?
no, not yet, ma'am.
Visible?
Not yet, ma'am. It just says Dr. Mita Singhal has started. Now, yeah. It's
I'll
yeah,
take it back.
yes, ma'am.
Now it's audible and visible?
The clarity is little less, but yeah, still it's okay, ma'am. I mean,
Audio is there?
audio, no, not yet.
No?
No, it's not. Means I can sense that it is running there. The sound is there, but it's not audible on
1
the
second, I'll
Zoom.
share it again. I'll share it again.
Yeah,
I'll share it.
yes, ma'am. Yes, ma'am.
I think there's a network issue. That's why it's not playing.
Okay,
कोशिश
ma'am.
करता है तो
Now
उसकी
it's
there
now-
audio video
Yes, yes,
या
yes,
जब भी आप
yes.
उसको उठाते हैं तो वो अपनी गर्दन को नीचे की तरफ रखता है, तो आप उसको उल्टा लेटा के बिस्तर पे या किसी तकिए के ऊपर इस तरह से आगे से खिलौने आवाज वाले दिखा सकते हैं, अलग अलग रंग के, ताकि बच्चा उसकी आवाज से अपनी गर्दन को उठाने की कोशिश करे। इसको और करने के लिए आप बच्चे की गर्दन को पीछे से स्ट्रोक भी कर सकते हैं। इस तरह से आप उसको गर्दन संभालना सिखा सकते हैं। अगर आपके बच्चे को करवट लेने में दिक्कत है, सीधे से उल्टा होना और उल्टे से सीधा होना, तो आप उसको करवट दिलाने के लिए ये ध्यान देंगे कि जिस तरफ करवट लेना है उसके जो सामने वाली टांग है उसको मोड़ना है और उसके सामने वाले हाथ को ऊपर की तरफ सीधा करना है। यहाँ से सपोर्ट देते हुए बच्चे को करवट दिलाना है। अगर उसको उल्टे से सीधा करना है, इसी तरह से जिस तरफ उसे सीधा करना है उसके सामने वाली टांग को मोड़ना है, हाथ को सीधा रखना है और फिर उसको सपोर्ट देते हुए आप सीधा कर सकते हैं। इस तरह उल्टे से सीधा होना और सीधे से उल्टा होना, करवट बदलना आप अपने बच्चे को सीखें। अगर वो बैठने की कोशिश करता है तो उसकी अगर गर्दन लटक जाती है या जब वो बैठता है तो उसकी कमर पूरी गोलाई में चली जाती है, तो उसको बैठना सिखाने के लिए आपको ध्यान देना है कि दोनों टांगों को एक साथ ऊपर की तरफ मोड़ना है, दोनों हाथों को भी उसके साथ लेते हुए बीच में उसकी गर्दन पे थोड़ा सा सहयोग देते हुए उसको ऊपर की तरफ बिठाना है। इसको आप कोशिश बार बार करेंगे तो बच्चा बैठना सीख सकता है। इस तरह से दोनों टांगों को ऊपर की तरफ करना, दोनों हाथों को बीच में लाना, गर्दन पे थोड़ा सहयोग देते हुए उसको आप बैठना सिखा सकते हैं। धन्यवाद। देंगे कि जब आपका बच्चा कुछ देर के लिए 15 मिनट आगे 2 तकिए लगा सकते हैं और उसके दोनों हाथों को आगे की तरफ ऐसे वजन दिला सकते हैं ताकि वो टिक के बैठ सके। जब वो ऐसे बैठा हुआ है तो आप उसको खिलौने दे सकते हैं आगे खेलने के लिए, जिससे वो दोनों हाथों से पकड़ सके, या फिर आप उसको खाना खिलाने के लिए इस्तेमाल या पानी पिलाना सिखा सकते हैं। उसके हाथ की मांसपेशियों से के लिए कोई टॉय दे सकते हैं जिससे वो अपनी हाथ के मांसपेशियों की वर्जिश कर सके। ये आप दिन में 2-3 बार कर सकते हैं। इससे धीरे धीरे बच्चे की बैठने की क्षमता में और बढ़ावा होगा। धन्यवाद। कि अगर आपका बच्चा बैठ तो जाता है बट बैठने की उसकी ज्यादा देर की क्षमता नहीं है या वो बैठता है तो गिर जाता है जल्दी से, तो आप घर पे बड़े आसान तरीके से घर के किसी कोने में या सोफे में आपको 4 तकिए चाहिए। इस तरह से 2 तकिए कोने में, एक बीच में त्रिकोण बना के लगा सकते हैं। नीचे की तरफ आप तकिया या कुशन कुछ भी जो भी इस्तेमाल कर रहे हैं या चादर भी बिछा सकते हैं। बच्चे को ध्यान से लेके बीच में आप बिठाना है। उसके दोनों हाथ आगे की तरफ होने चाहिए। अगर वो खाना खा रहा है, टीवी देख रहा है घर में, तो इस तरह से आप उसको बिठाएंगे तो उसकी धीरे धीरे बैठने की क्षमता बढ़ेगी। धन्यवाद।
Thank you, ma'am.
Anything anybody wants?
So we'll take up a minute or two for questions. Anyone who wish to ask any questions, you're most welcome to put it in the chat box or unmute yourself and ask questions, please. Any questions? Looks like either they have understood everything or they've not understood. No, that is when there is no questions is the thing. I mean, typically, I'm not sure. Sure. I'm asking the audience out there. Any questions? So, ma'am, I think since there's no questions, we shall wind up the session. So, to end the session, I would like to express my gratitude. So, first and foremost, my heartfelt gratitude to our director, Dr. Suman Kumar sir, for being supportive and for being encouraging us to take on these awareness programs, for motivating us to take on all, whether it is online, offline. Even today, I think after this, we have the White Cane Day celebration in the institute. So, lots of things happening at all the national institutes. I believe even I think at IPH also it must be the same thing. Yeah, ma'am. Secondly, yes, thank you, Dr. Mita Singhal, ma'am. Thank you so much for the wonderful presentation and the way you have. It's a wide topic. I know this time is not sufficient, but in spite of that, you have made it such a wide topic in a very, I mean, beautiful and very comprehensive way. You have put across, touched all the important points. So thank you so much. Thank you very much, Dr. Mita, ma'am. I would also like to thank Dr. Asavari Shinde and Mr. J. Thorat sir, who are the coordinators of this calendar of activities events at AYJ and HSD, for all the coordination and for ensuring that all these events are taking place and helping me out in putting up this program on, in spite of me missing out on October 6th, helping me to even reschedule the thing for today. Yeah. And thank you so much, Kalpita, for the sign language interpretation. I mean, it's with all the internet issues and things, we were just trying to coordinate where she be and all that. So somehow everything fell in place and she quickly took up the task. So thank you so much, Kalpita. Last but not the least, my wonderful audience. Thank you so much. I would have loved if someone would have come up with some questions, but looks like you are not either hesitant. I don't know what is it that you don't want to ask, but thank you so much. Thank you for joining this event today. Thank you once again. Thank you all once again. Thank you, ma'am. Thank you, Mita, ma'am, once again. Thank you so much.
Okay.
Yeah.
Thank you.
So I shall end the meeting now. Yeah.